Yes, we are about to start our next session. The session about to commence is Medicine, Nephro and Rheumat. And let's not forget, we are in the India's biggest medical PG prep academic event, the DAMS Visual Treat DVT 2023. Apna time apun khud laega. We warmly welcome Dr. Srinath Chandramani, who is about to take the session of Medicine, Nephro and Rheumatology. Dr. Srinath is a MBBS from GMC Mumbai. He's done his DNB from Pune Hospital. He's done PG Diploma in Geriatrics. And he is a faculty in DAMS since 2010. We welcome you, sir. Over to you.
So, good morning, everyone. Let me start with this message to all of you. A generation ago, becoming an MBBS doctor and setting up a clinic realized the dreams of many. But now, MBBS has sadly become more of a graduation rather than a doctorate, given the fact that very few develop the confidence to practice their skill. Post-graduation has now become the new way to realize the doctor's dream for majority. But the entry to this dream comes with an entrance exam for which every medical graduate puts in his or her best efforts. But it takes revision and effective recall of all the knowledge to realize this dream. To ensure you do that, we at DAMS have put in our heart and soul, left no stone unturned to give you DVT. So here I am, Dr. Srinath Chandramani, doing my bit for all of you, bringing you this session R to R, that is renal to rheumatology in 2 hours. So I hope you're all ready for day 3 and ready to come on our journey to help you realize the dream that all of you cherish. So let's get started with the session. You can see the workbooks are ready. The workbooks have got simple spaces, and at the end of the session, the completely filled workbook will be uploaded in the PDF format. So good morning, everyone. Good morning. Lovely to see all of you on the chat box. It's a pleasure to be with you. So let's get started with the best one. So in nephrology, our approach as always remains very important, methodical, structured, concise but comprehensive. So I'm going to go one by one. I want all of you to speak loudly. Remember, you are in the comfort of your own house. Even if you shout, nobody is going to object. So read your answers aloud. Use your brain. Start the gray cells working and we will get there together. Right. So the first step in nephrology, if I ask you what are the functions of the kidney, we say the kidney does diverse functions. We can say that the kidney does diverse functions. It plays an important role in excretory function. It also plays important role in homeostasis and in hormone synthesis. So when we come to diseases, there are many diseases that can affect the kidney. The kidneys can be affected by vascular diseases, by infections, by drugs, by toxins, autoimmune disease and neoplasm. But whatever the disease pathology might be, the symptoms of the renal diseases can be divided into the 2 groups that we are going to start with. The first set of symptoms are due to the function affected. As I mentioned, the kidney does diverse function, but the most important function is the excretory function. Since excretory function is most important, that is the first one to be affected. So in any kidney disease, the most common symptom is going to be one or more of the uremic manifestations. One or more of the uremic manifestations are going to be are going to be the first symptom to come. These uremic symptoms may be common, but unfortunately they are non-specific for the diagnosis because they occur both in acute kidney injury and chronic kidney disease, irrespective of the cause. So whenever you get a question related to renal failure, it is likely to be related to uremic symptom. One or more uremic symptom is there. We know there is a renal dysfunction. There is a renal dysfunction. However, the symptom is uremic manifestation, which is non-specific. Along with that, if there is a homeostatic defect, that is water balance and acid-base balance defect, most likely the patient is going to come with oligoanuria. Rather than coming with polyuria. Both can be presentation depending on the disease. Among the acid-base balance defect, the most common defect will be metabolic acidosis more than the metabolic alkalosis. The symptom due to erythropoietin deficiency is likely to be leading to the problem related to anemia. And metabolic bone disease can occur due to vitamin D3 deficiency. And the most common defects, there are 3 types of metabolic bone disease associated with CKD. The number 1 most common is the osteitis cystica fibrosa. Most common is the osteitis cystica fibrosa, which occurs due to secondary hyperparathyroidism. Patient also may present with adynamic bone disease. As the name says, due to lack of movement, adynamic bone disease can occur due to remodeling defect. And number 3, patient may present with rickets or features of osteomalacia depending on age of the patient. Yes, so I'm starting slowly. Please don't have to rush me. I'm well aware of what I have to do. So we are starting. Always in the first 10 minutes I go slow so that all our Indian students can join, because it's our age old tradition. In India 10 बजे का क्लास है तो 10:05 को लॉग इन करना हमारी आदत नहीं, हमारी ट्रेडिशन है. So I always start slow. So but we'll pick up speed, trust me, and we will stick to the time as we have written hour to hour in 2 hours. So first set we have done here that functions of kidney are diverse. Most likely they will give uremic symptom. They can have homeostatic defect. They can have hormone related imbalance in a patient with renal failure. These are common questions related to symptom. Take it to the next set. The symptoms due to site affected. Very important. In medicine, whenever patient has got a problem, the question we have to answer, where is the problem? The kidney can be affected by defect in the renal blood flow, that is pre-renal, defect due to renal component, that is renal AKI, or due to defect in the collecting system, that is post-renal AKI. I want you to enumerate what are the symptoms due to site affected. If the patient has got a pre-renal AKI, which is the most common site affected, patient presents with concentrated oligoanuria. Patient presents with concentrated oligoanuria. If the patient has got a renal AKI can be subclassified into the 2 types, glomerular disorders and tubulointerstitial disease. In glomerulonephritis, the most common symptom patient can come is hematuria. Patient may also present with proteinuria leading to the symptom frothy urine. But along with that, some of the patient may present with symptoms related to edema and anasarca. Or patient presents with hypercoagulable state. These are the two presentations of our renal AKI, that is glomerulonephritis. Can come with the nephritic syndrome or with the nephrotic presentations. Both suggest site of the disease is GN. In tubulointerstitial disease, there is a defect in concentration. Hence, the patient presents with dilute polyuria. This presentation in our exam is called as the non-oliguric AKI. When patient comes with non-oliguric AKI, the diagnosis is written as tubulointerstitial disease. And in a patient with post-renal AKI, which is also known as obstructive uropathy, the most common symptom is patient going to come with loin pain with or without LUTS, lower urinary tract symptom. So in our session, we are going to revise all the notes that we did in nephrology. So we started with first page, the symptoms of renal disorder. So symptom related question, we have got it answered. Let's go to the next step. The next step is to know about the details of acid-base balance. Very important. This page, very important. Out of this page, 100% question will come. Whether it is inicet, whether it is NEET PG, whether it is UPSC. Every year, this page, 100% one question will come. So two disorders related to acid-base balance. One is RTA, other is the channelopathy. So first look at patient with RTA. How do you diagnose patient has got RTA? Diagnosis is confirmed when the patient is got normal anion gap metabolic acidosis with high or positive urinary anion gap. RTA is diagnosed when patient is having normal anion gap acidosis with high urinary anion gap. Yes, last slide. So there is no hurry. Last slide bhi aayega, first slide bhi aayega. So it will all come. So these we discussed symptom. Lower urinary tract symptom is the LUTS. Okay, chaliye, aage badhenge. So in the RTA, diagnosis is confirmed when patient has got normal anion gap in the plasma, high urinary anion gap in the urine. So what are the types of RTA? Total, there are 4 types, out of which type 3, odd man out. It is the marble brain, marble bone disease. So we want to compare between the most dreaded and the most common in practical terms. So I have listed down key points to remember in each of the column. Go one by one like a story. The type 1 RTA, also called as the distal RTA. Type 1 RTA, called as the distal RTA, is the most severe. Hence, it presents in children before 10 years of age with a male preponderance. Comes in children below 10 years with a male preponderance. And there is a defect in the H plus K plus ATPase pump. There is a defect in the H plus K plus ATPase pump is the problem. What are the association? Very important. Associations. 30% of cases are associated with autoimmune disease, especially Sicca syndrome. And important drug-induced cause are the use of our very important liposomal amphotericin B. So due to our recent COVID epidemic, we had use of mucormycosis, and that can cause the use of amphotericin B. Also can come with type 1 RT. The clinical feature, the young boy presents with short stature, presents with short stature associated with risk of renal calculi. Nephrocalcinosis is very important due to development of hypercalciuria. In this patient, along with correcting acidosis, you can give bicarbonate supplement, potassium supplement, magnesium supplement, and the citrate supplement can be given. But since there is no cure, the prognosis remains worst disease to have. Correct. Very good. Come to second column. In type 2 or the proximal RTA, the epidemiology is milder. Hence, patient is a young adult. It is a young adult who will come to the thing. And this patient, the defect is in the bicarbonate reabsorption. Now comes the question, why the name? Because the defect is in the PCT, while type 1 defect is mainly in the collecting duct, which is part of the distal nephron. What is the association? Fanconi stride. When there is glycosuria, there is going to be phosphate urea and there is going to be amino acid urea. This is the very, very famous question, Fanconi stride. When we have got Fanconi stride, answer is always type 2 RTA. How will they present? The acidosis itself is mild and asymptomatic, but they present with D3 deficiency related bone disease. They related to bone disease. They will present with. But in this patient, once you give D3 responsive, it is D3 responsive, hence associated with a favorable diagnosis. So please don't correct. Carbonic anhydrase defect is type 3 RTA, students, not type 2. Type 2 is defect of bicarbonate reabsorption. Fourth column. In the type 4 RTA, that is also called the hyperkalemic RTA. This is the most common in practice. But luckily it is also the mildest type of RTA. Since it is mildest and also acquired causes, we can say that the age of presentation is elderly, after 50, equal in both gender. The defect, there is a defect in the aldosterone. So there is a defect in both H plus and K plus secretion. Defect in both H plus and K plus secretion, leading to hyperkalemic acidosis. That is the key word. They are asymptomatic. Majority are incidental diagnosis. But we are worried about the arrhythmias related to hyperkalemia, can be dreaded complication of the disease. They don't have any symptom. They are associated more with drugs. So mainly with which drugs? With ACE inhibitor use, with ARBs, the potassium sparing diuretics. And only thing you have to do is stop the drug. And once you stop the drug, you get a potential cure, making the prognosis best among the RTA. So look at this table carefully. To diagnose RTA, we need two things on ABG: normal gap in plasma, high gap in urine. Total there are 4 types, but out of the 4 types, we are focusing on the 3 types, because type 3 is the one, marble brain, marble bone disease, defect of carbonic anhydrase, and least common defect. So we have made a comparison. So typical MCQ question, which disease is going to be responsive to D3 is type 2. Which one has Fanconi syndrome? Type 2. Which one comes with amphotericin B? Type 1. Which has hyperkalemia? Is type 4. Most common is type 4 RT. These are the typical questions that have come year after year. The younger brother that we have is the inherited channelopathy. The younger brother is inherited channelopathy. So Niharika, one student wants to know what is urine pH. Only urine pH more than 5.5 is diagnostic of type 1 RTA. In all other disease, urine pH is as expected. Urine pH is as expected. That's the correct answer. Thank you everyone. Yes, Ashish, I'm very happy. All are amazing. Go for it. Kill it. Chalo. Inherited channelopathies of the renal tubule. Now make the comparison. Again, exception is the Jordan syndrome. The exception to the rule is the Jordan's syndrome. The Jordan's syndrome is the only disease, is the only channelopathy with inherited channelopathy with hyperkalemic metabolic acidosis. It is the only channelopathy with hyperkalemic metabolic acidosis is going to be there, associated with metabolic acidosis. That we will take it as the exception to the rule. Focus on other three. Focus on other three. So the other three channelopathies, all of them present with the same hypokalemic metabolic alkalosis. Hypokalemic metabolic alkalosis is the presentation in all the RTS. In all the RTS, there is hypokalemic metabolic alkalosis that we see except for Jordan's. So if we compare, the most severe is Barter's syndrome. It is the most severe type of RTA. Hence the patient comes as a child before 10 years of age with a slight male preponderance. With a slight male preponderance we are going to get. The defect is in the sodium potassium 2-chloride ATPase pump, and it is a autosomal recessive inhibitory defect. Autosomal recessive inhibitory defect of the sodium potassium 2-chloride ATPase pump. The drug that mimics the channelopathy is the loop diuretic use. Clinical feature, they present with severe dehydration. They present with severe dehydration. They also have risk of renal calculi, and that is because of the presence of hypercalciuria. That is keyword here. So MCQ, hypercalciuria differentiates the Barter's from Gitelman syndrome. What treatment you can give? It is the NSAID responsive channelopathy. It is the NSAID responsive channelopathy. MCQ is the NSAID responsive channelopathy because majority patient will have elevated levels of prostaglandin. Hence this is the channelopathy responsive to NSAID. Come to Gitelman. The Gitelman syndrome is relatively mild. Hence it presents between 20 to 30 years of age. There is a defect in the sodium chloride co-transporter. Again, it is a autosomal inhibitory defect. Autosomal inhibitory defect of sodium chloride co-transporter mimicked by thiazides. They present with mild dehydration, but all the features are due to hypomagnesemia, which can even cause paralytic ileus and arrhythmias are the dreaded feature. So this channelopathy responds to magnesium supplementation. Important is magnesium supplementation is important in this channelopathy. While in Liddle's syndrome, it is again mild, presents in the young age, equal in both gender, where there is a autosomal dominant stimulatory ENaC defect. Autosomal dominant stimulatory ENaC defect, which can be mimicked by use of steroids. They present with young onset hypertension before 30 years of age, and the treatment drug of choice is amiloride. But in Liddle's patient, the serum aldosterone level is unmeasurable. Hence, it is called pseudo hyperaldosteronism. Actually, there is no aldosterone, but it looks as if there is hyperaldosteronism. Hence, we call it pseudo hyperaldosteronism. While Jordan's is the disease which we call as the pseudo hypoaldosteronism. Which can be treated with thiazides. The treatment is to give thiazides. So very, very important for MCQ are the channelopathies and renal tubular acidosis. So give it adequate time in your revision. Definite topic to revise on the day of exam are these two slides, that is RTA and channelopathy. We have revised. I can see from the chat most of you are well read, well prepared and answering the questions right. Let's take the story forward. So if the patient has come with uremic symptom, we go for the screening test. And one of the most important screening tests is urine analysis. But unless you can read what is there on urine analysis, you cannot become an expert in diagnosis. I'll tell you, when I say that on the urine report, proteinuria is 2+, अबे ये तो हमारा वार्ड बॉय भी पढ़ सकता है ना. रीडिंग द रिपोर्ट इज अबाउट इंटरप्रिटिंग. सीइंग द रिपोर्ट वो तो रिलेटिव एंड वार्ड बॉय भी करते हैं. बट टू बिकम डॉक्टर you have to learn to interpret the report. That's what are the two slides here. Very two important. Proteinuria, hematuria. Come on, hit it now. Hit it now for me. So what is the thing here? Right. So we want to start with this. If the patient has got proteinuria, we want to screen using dipstick method. When you do the dipstick method, we want to first confirm whether the quantity is significant. When do you call it significant? When the quantity is more than 150 milligram per day. But on the dipstick method, if it is 2+ or more on the dipstick method, it is considered significant proteinuria. On the dipstick method, when it is 2+ or more, it is considered significant on the dipstick method. But all proteinuria are not significant. You want to compare them with clinical correlation and abnormal creatinine. If the patient is asymptomatic, it is considered non-specific finding, does not need further evaluation. But if the patient is having clinical symptoms of nephropathy and elevated creatinine, it is important. What next test will you do? I will go for 24-hour urinary protein estimation. I will do 24-hour urinary protein estimation. I want to do protein estimation. We want to do. So Dr. Rakesh is asking, where will you get PDF of this session? भाई लाइव चल रहा है यार. अब PDF भरूंगा तब बनेगा, फिर सेशन के बाद आपको मिलेगा, है ना. सो राइट नाउ जिस पेज पे हो आप कंटिन्यू करिए, आगे PDF आते रहेगा आपके पास. राइट. So 24-hour urinary protein estimation we want to go for, right? Because proteinuria most common cause is overflow. That's why asymptomatic patient mein it is considered non-specific. But based on quantity, what will we get? If it is less than 2 gram per day, we call it tubular. tubular range proteinuria more than 2 gram is considered as glomerulonephritis, is glomerular range proteinuria. Glomerular range proteinuria. So less than 2 gram indicates there is tubulointerstitial disease. Tubulointerstitial disease. I'll tell you clearly that the protein to creatinine ratio is not as reliable as albumin creatinine ratio. So the gold standard test is not PCR. The gold standard test in protein is to go for 24-hour urine. Okay, आपका doubt clear करते चलेंगे. But more than 2 gram indicates the disease is glomerulonephritis. The disease is glomerulonephritis. Glomerulonephritis. Right. So who is telling to talk in English? Zayan. Ana, chalo yaar. English is to baat. English is only going on. Sometime we can use what is relevant. Okay, chalo. So in glomerulonephritis, we have again subclassified them into two. If it is going to be less than 3 gram, we call it nephritic syndrome. And if it is more than 3 gram, we call it nephrotic syndrome. Less than 3 gram, more than 3 gram, we classify them into nephrotic syndrome. Ada pode, ana Tamil, English, Hindi. Are Indians hai na? You have not what chakde ha? You have to, what is the answer? Where do you belong? You are Indian. Ana, you are not divided by any territory nor language. And come on, we can understand this much. Right? Chalo. So go for it. Let's not divulge. Proteinuria. Very important finding in the dipstick. That will help us identify where is the problem and what is the problem. It can identify. But next one is the hematuria. Next one is the hematuria. Chalo, let's pick up the pace. Hematuria. So significant hematuria. Any one of the following is required to consider that it is significant. It is significant. When do you call it significant? Number one, the hematuria has to be symptomatic. Hematuria has to be symptomatic. And more than that, it has to be or more than 100 RBC per high power field, or it has to be present on 3 or more occasions. It has to be present to be called as the significant hematuria. To be called as significant hematuria. Any one of the following. But once it is significant, look closely at RBC morphology. What you will find? What you will find? More commonly, you will find that the presentation RBC morphology is normal. That is eumorphic. If it is eumorphic, it indicates there is a post-renal defect. And the most common cause is going to be urinary tract infection, followed by renal calculi, and the rare cause like carcinoma bladder. Rare cause like carcinoma bladder. So during the revision, let me just tell you that the part is not understanding. Understanding part you have done already. This is about revision. If you are not able to understand some concept, don't worry, put it away for now. This flowchart is what will help you crack exam. So eventually, if you are interested, go back and read the concept. Don't worry about that. See, every time focus has to be clear. Medicine OPD, when you are practicing, what they tell you? You focus on common causes first. But when you are in emergency, what they tell you? Focus on dreaded causes first. Same way, when you are reading notes, you focus on concept. But when you are revising, you focus on hits. You want answers. You don't care about concept now. So this is like a emergency medicine now on a DVT. Let's go for it. So what is the point here? In patient with RBC morphology, if it is dysmorphic, then it indicates glomerulonephritis. Then it indicates glomerulonephritis is going to be there. But based on the serum complement level, serum complement level, two possibilities. If the serum complement level is normal, serum complement level is low. If the serum complement level is normal, most likely cause is IgA nephropathy. But if the patient given is a child, answer can be HSP, is the differential diagnosis. But in patient with normal serum complement level, what you do? You repeat the test. You will repeat the test after few weeks. If you repeat the test and if it returns to normal, then the answer is post-streptococcal GM. But if it remains persistently low, answer is autoimmune disease. And the most common cause is lupus nephritis. So significant hematuria, if it is there, these are the orders. We look at the shape, then we look at complement, then we give the probable diagnosis in each one of these cases. Beyond the diagnosis of where is the problem, we want to take it further. We want to look also at the caste present in the urine. Pace badhate, caste present in the urine. The presence of hyaline caste is the most common caste present in the urine. Most common caste present in the urine. But it is also considered the most benign caste present in the urine because no treatment is required. Needed in this patient. That is hyaline caste. But the presence of granular caste is considered the most common caste present in cases of nephropathy. Right? The presence of RBC caste indicates specific for acute glomerulonephritis. The presence of WBC caste. Surabhi is asking, dipstick method we don't do. Hematuria we use microscopy. So in microscopy we have written significant hematuria. Our WBC caste is diagnostic of the acute pyelonephritis. It is specific for acute pyelonephritis. So Dr. Pulkit, Jordan's में same channel as Gitelman, but सिर्फ stimulate होता है. पुलकित के लिए जॉर्डन सिंड्रोम में सेम चैनल एज जिटलमैन इफेक्ट होता है बट स्टिमुलेटरी डिफेक्ट होता है. राइट, आगे चलेंगे. प्रेजेंस ऑफ मडी ब्राउन कास्ट इज डायग्नोस्टिक ऑफ अक्यूट ट्यूबुलर नेक्रोसिस. eosinophiliuria indicates acute interstitial nephritis. It is the broad waxy caste which is considered the worst caste present in the urine, only seen in advanced CKD cases. We can see, right? So this is what we have here is the concept of the interpretation of urine report is what you want to know. Once you have looked at the urine report, we come to the first step, that how to differentiate between acute kidney injury and chronic kidney disease. Acute kidney injury and chronic kidney disease we want to study. So what is the classification we have adopted? We use the KD-IGO criteria. That is the kidney diseases. Improving global outcome. The kidney diseases improving global outcome is the criteria we want to use in order to confirm the diagnosis of acute kidney injury, we want to use that, right? So we want to look at the problems. Where is the disease that we already got? Whether disease is tubular necrosis, whether it is interstitial nephritis. The photo you will see in pathology class. Photo you match with pathology class. Okay? So that's how you interpret. Yes, many cast can be there. Interpret what is specific. Come to the important table. When patient has got the elevated creatinine, it is important to differentiate whether it is acute or chronic kidney disease. So you tell me now, okay? First enumerate all findings of AKI. Come on, everybody. In acute kidney disease, the CMD is normal or preserved. The size of the kidney can be normal or enlarged. The cast present most common will be hyaline cast. Anemia can occur rarely, but metabolic bone disease is never present. Metabolic bone disease is never present. So you will suspect it is a case of AKI. When other than creatinine, everything else is normal. But look closely, none of them are specific to confirm diagnosis. There is no star. That is why we take help of KD-IGO criteria to confirm diagnosis. According to KD-IGO criteria, either the urine output should be less than 0.5 ml per kg per hour for more than 6 consecutive hours. For more than 6 consecutive hours, or there has to be rise in the serum creatinine by more than 0.3 milligram within the 48 hours, or there has to be 1.5 times increase in the creatinine within 7 days. Both can be taken as the diagnosis of acute kidney injury. Acute kidney injury. Very good. That is our diagnosis of AKI. Must know criteria. But what about CKD? How to diagnose CKD? In the CKD, the CMD may be normal, but if it is lost, it will get a star. Star means specific. The size of the kidney may be normal, but if it is shrunken, it will get a star. So question, what are specific features of CKD? Star feature. The presence of broad waxy cast will get a star. Anemia is common, but no star, can occur in acute also. But metabolic bone disease, if present, will get a star because it is specific of CKD. It is specific of CKD. So in the diagnosis, you need either the presence of one or more of the star findings present, or you can diagnose if there is a documented renal disease. If there is a documented renal disease of 3 or more months duration. So read carefully how to confirm diagnosis of CKD. So chronic kidney disease, if any one of these star feature is there, loss, shrunken kidney, broad waxy cast and metabolic bone disease, any one of the star feature is there, or if there is disease more than 3 months duration, diagnosis of CKD is confirmed. Diagnosis of CKD is confirmed, right? Once we diagnose, we proceed to the management. In AKI, it is important. Take this forward. AKI. Let's take this forward. In the patient with AKI, chalo, Kirtika, what is criteria? Urine output is less than 0.5 ml per kg per hour for 6 or more consecutive hours. rise in the creatinine by more than 0.3 milligram in 48 hours or rise in creatinine 1.5 times the baseline within 7 days is diagnostic of acute kidney injury. It is a must-know guideline. There is no role of steroids in CKD. Because why, Ashish? The question is wrong, beta. CKD बीमारी नहीं होता. CKD is not a disease. You give steroid according to cause. If the cause of CKD has got any role of steroid, so patient has got nephrotic syndrome which has gone into CKD. Patient is having membranous nephropathy going into CKD. Then I will give steroid. Understand concept? CKD का ट्रीटमेंट नहीं होता. CKD के स्टेज और कॉज का ट्रीटमेंट होता है. तो ऐसा क्वेश्चन नहीं सोचना, अलग से सोचना. आगे लेके जाएंगे. So in patient with AKI who is confirmed diagnosis, AKI confirmed diagnosis using KD IGO criteria. RBC more than 3, RBC more than 3 RBC, less than 100 RBC is for more than 3 occasions. ठीक है, 3 criteria हमने लिखा अनुज. ठीक है. So what about this? Acute kidney injury है. How to differentiate? Where is the problem? What we have said? Most common is going to be the pre-renal AKI in 85% cases. But 10 to 15% cases will be renal AKI or the intrinsic AKI. Come on, fill in the blanks for me. Fill in the blanks for me. We want to do Akriti. Why not GFR? Because GFR varies every few hours in AKI. Anna, just focus. Again I told you, why not mat पूछो, why yes को देखो, अभी ये time है, why yes. So in pre-renal AKI, the serum creatinine to urea ratio is more than 20:1, elevated. Urine osmolarity is more than 500, concentrated urine. But the urine sodium is less than 20 milliequivalent. FeNA is less than 1%. And the novel biomarker should be negative. Novel biomarker should be negative. Already I have typed out the biomarker, so we don't waste time on writing this long spelling. Out of the biomarker, only the first 2 are considered FDA approved biomarkers. The rest are experimental biomarkers which we use in our country. The rest are the experimental biomarker which are also available in our country. So compare with renal AKI. Renal is confirmed when urea creat ratio is less than 12:1. That is normal. In the urine osmolarity less than 350 because there is dilute urine. Match it with symptom. Urine sodium is more than 40. FeNA is always more than 2%. And novel biomarker, if present in the urine, is specific, gets a star, specific for AKI, is specific for AKI, renal AKI. Diagnosis is complete. So you know where is the problem. Take this forward. Take it forward to the next level. So how to differentiate? If it is renal AKI, how to differentiate between more common is the tubulo-interstitial disease, but the dreaded is the glomerulonephritis. Tubulo-interstitial disease versus glomerulonephritis divided based on what we just discussed: proteinuria, hematuria, caste. Put the indication. In the urine analysis, if the proteinuria is tubular range less than 2 gram per day, hematuria is absent and granular caste is present, diagnosis is tubulo-interstitial disease. But in glomerulonephritis, proteinuria is more than 2 gram per day. Hematuria is both common and what is the shape we have written? Dysmorphic hematuria. And caste is the RBC caste. If present, gets a star for diagnosis of glomerulonephritis. That is how you identify the question and answer. Any renal AKI with glomerular range proteinuria, dysmorphic hematuria, with or without RBC caste confirms it is GN, like a story. So we started with renal failure. Once we got AKI, we did pre-renal versus renal. Among renal, we differentiated tubulointerstitial into glomerulonephritis. Now take this GN forward, tubulointerstitial disease forward. If the patient is having tubulointerstitial disorders, patient is having tubulointerstitial disorder, which is most common site? Most common site is the tubular necrosis, but relatively it is more severe. The other site can be the acute interstitial nephritis, can be there, which is relatively milder as compared to the two. We are going sub-classification. We are doing sub-classification we want to do. So Shravan, Subramaniam, if you cannot recall, time has gone to rewatch lecture, rewatch DVT, no? That's what you are doing. Why your mind is not able to focus on present? This is the revision. Forget what you can recall. If you cannot recall, that's why I am here, no? To help you recall. So right now, focus on what is going on. Tubulointerstitial is there. Go for diagnosis. How to reach diagnosis in this patient? How to give treatment. Chalo, fatafat finish. In tubular necrosis, FENA is more than 4%. It is the presence of muddy brown cast, which is specific for diagnosis of acute tubular necrosis. The most common cause is the end point of delay in the treatment of shock. Delay in the treatment of shock. That is what is most common cause. So what you want to treat? You want to treat the underlying cause. So you want to give IV fluids. You want to treat the underlying cause. But the recovery takes more than 6 weeks. The recovery takes more than 6 weeks. Hence the recovery is more prolonged. Recovery is more prolonged. And there is a 1 to 5% risk of end stage disease. Hence the prognosis is relatively unfavorable. While in a patient with the acute interstitial nephritis, FENA is only mild derangement, 2 to 4%. FENA is having mild derangement. Specific cast is eosinophilic cast, because the most common cause is allergic response to drug. Most common cause is allergic response to drug. Drug induced is the most common cause, and most common culprit in modern medicine is NSAIDs. Most common culprit in modern medicine is NSAID. So all you have to do in the treatment is to stop the drug. Once you stop the drug, recovery occurs within 1 to 2 weeks. And the risk of progression to end stage disease is less than 1%. Hence the prognosis is considered relatively more favorable. Hence the prognosis is considered relatively more favorable in patient with interstitial nephritis. Prognosis is relatively favorable. Yes, Sham. You can consider steroid if to fasten the recovery. To improve the recovery rate, you can give steroid. But mainly you want to stop the drug. That is the main treatment. Steroid only in severe cases to lessen the duration of recovery. So done. Tubulointerstitial disease done. So FENA is fractional excretion of sodium in the urine. Fractional excretion of sodium, that is FENA. right? So now come to the patient with glomerulonephritis. This is our favorite topic. Just fill in the blanks for me. Fatafat, fill in the blank for me. If patient comes in crush injury, myoglobinuria, Arvind Kumar, can cause the acute tubular necrosis. In crush injury, road traffic accident, myoglobinuria. Multiple mechanisms are there causing acute tubular necrosis. We have written, right? Chalo. So, clinical classification of GN. First, look at the clinical presentation. Nephritic or nephrotic syndrome. If it is nephritic syndrome, look at the antibody present. Elevated IgA means patient is IgA nephropathy. IgA nephropathy, which is most common cause. What is fatafat? Shruti. Fatafat means fast. Tada tadi. Ana fast. Romba. Avasarama pandarde. Ana this is all languages I know. I don't know more than that. So maybe you can figure it out. Ana laukar करायचंय. फटाफट करायचंय. चलो. Anti-DNase antibody indicates PSGN, which is the most common cause of nephritic syndrome in India. The anti-double-stranded DNA is specific for lupus nephritis. Punjabi में आप ही बता दो यार, है ना? Lupus nephritis. ANCA indicates vasculitis syndrome. Is the vasculitis syndrome. And anti-GBM is the good pasture syndrome, which is least common cause. Is the least common cause of our disease. So that is our least common cause of nephritic syndrome in the world. So nephritic question is there. Look at the antibody. Accordingly, mark answer. But what if you get a nephrotic syndrome? In nephrotic syndrome, you want to look at the age of onset. If the person is a child below 10 years of age, especially male dominant, answer is minimal change disease. Answer is minimal change disease. Chitti crow. Okay. Chalo. Thank you so much. So adult onset 30 to 50 year most likely causes FSGS, focal segmental glomerulosclerosis, where the most common cause is end point of diabetes. Most common cause is end point of diabetes. While elderly patient after 50 think of membranous nephropathy. Membranous nephropathy, that is MGN you want to think of. Among the nephrotic syndrome, it is the membranous nephropathy which has got the worst hypercoagulable state associated with maximum risk of renal vein thrombosis. Associated with maximum risk of renal vein thrombosis. Yes, HIV. What will HIV cause? The rare cause of FSGS is HIV associated nephropathy, but it is the worst type. It causes collapsing type of FSGS. It causes collapsing type of FSGS is seen in the HIV associated nephropathy. So whenever you get the question of glomerulonephritis, first we want to look at the clinical classification, nephritic versus nephrotic syndrome. In nephritic syndrome, it is important to look at antibody present. In nephrotic syndrome, it is important to look at age of onset. But there are only 3 indications for biopsy. Read with me. If serology is inconclusive, if the patient is refractory to treatment, or if there is progression to RPG. These are the only 3 indications to the glomerulonephritis to do renal biopsy. If you do renal biopsy, what will you check for? What will you check for? You will check for the immunofluorescence pattern. Proliferation is there. Look for immunofluorescence pattern. You want to look for. MCD full form is the minimal change disease. is the minimal change disease you want to look for. Okay, take it forward to the biopsy finding. In the biopsy finding, chalo, identify pattern for me. What is this pattern? The pattern shows granular immunoglobulin deposit. This is called as the granular pattern of immunoglobulin deposits on the GBM. That is the granular pattern. Granular pattern has got two causes. Both of them are also called as the post-pharyngitic causes of GN. Both of them are the post-pharyngitic causes of glomerulonephritis. So what are the two differentials? Either the patient is suffering from IgA nephropathy or post-streptococcal GN. Chalo, 10 minutes. We want to finish. Very simple. Post-pharyngitic causes of GN. History of sore throat is there. When will you say answer is IgA nephropathy? When patient is a young male. Latent period is less than 1 week. They present with recurrent gross hematuria. They present with recurrent gross hematuria. Serology shows elevated IgA1 level. Complement levels are normal. Complement levels are normal. The treatment is mainly to give reassurance only, and the risk of RPGN is less than 1% risk of RPGN. Hence the prognosis is best prognosis among the patient with nephritic syndrome. Best prognosis among nephritic syndrome is IgA nephropathy. So typically young male, recurrent hematuria within 1 week of sore throat, elevated IgA, normal complement, don't do anything, self-resolving disease. But PSGN, when will you mark? When patient is a school-going child. Patient is a school-going child. Latent period is longer, 1 to 3 weeks, presenting with the classical nephritic features. The serology will show 70% cases have anti-DNase positive, 30% cases have ASO titer positive. Serum complement levels are initially low. So you can see, even though we are revising, we still did everything. Application of that knowledge. Treatment is to give penicillin, but no long term is required. Prognosis is second best. Risk of RPGN is 1 to 5% risk of RPGN only. Prognosis is second best. So that is how you solve answer. There is no luck factor in exam. It is your preparation and your awareness. This is important. Applying the knowledge that you have. So if you have post-pharyngitic GN, you have to choose between the IgA nephropathy and PSGN. We want to choose with. Great. Chalo. Now go to the next one. Tell me what is this pattern. The first pattern is the linear pattern of immunofluorescence, also known as the ribboning of the GBM. And we have got the pauci-immune pattern of immunofluorescence. Both are giving us diagnosis. Linear pattern on biopsy indicates it is a case of good posture syndrome. Pauci-immune pattern tells me vasculitis syndrome. But both of them are specific for the pulmonary renal syndrome. Both of them are the differential diagnosis for pulmonary renal syndrome. So pauci-immune is vasculitis, linear is good posture. Come on, fill up the column for me. In the patient with good posture syndrome, antibody is against alpha-3 subunit of the type 4 collagen. Alpha-3 subunit of the type 4 collagen. There is the problem. Clinically, they present with only two organ involvement, only with two site involvement. They present with hemoptysis and hematuria, lung plus renal, hemoptysis plus hematuria. And serology shows there is presence of anti-GBM antibody present with linear pattern of immunofluorescence deposit with maximum risk of RPGN, making the prognosis worst. Direct you give first line therapy, go for plasmapheresis. But mortality is high, making the prognosis worst prognosis among the patient with nephritic syndrome. Among nephritic syndrome, it has got maximum risk of renal failure and death of the patient. But in vasculitis syndrome, these are the ANCA-mediated small vessel disease, where they present with pulmonary renal plus any other organ involved, plus any other site involvement present. So patient can have skin rash, uveitis can be there. It is not good posture, it is vasculitis. Serology shows the patient majority are ANCA positive. You will get sparse immunoglobulin deposits on the GBM. The risk of RPGN is 30 to 70%. So first you will give steroids, but if there is RPGN, you give plasmapheresis. So it becomes the second worst prognosis among the patient with nephritic syndrome. Second worst prognosis among the nephritic syndrome is our vasculitis syndrome. So we covered whole topic in glomerulonephritis, nephritic syndrome, post-pharyngitic IgA versus PSGA. In nephritic syndrome, along with lung involvement, pulmonary renal syndrome, it is either good posture or it is vasculitis syndrome. We want to differentiate. Done? Take this forward. So age is common to both, 30 to 50. Age is common to both. Male dominant disease. Male dominant disease you are going to see. Right? So take this forward. Last slide for nephrology. Tell me, what are the indications for? What are indications for emergency dialysis in acute kidney injury? Specific I am asking. Emergency dialysis for acute kidney injury is going to be there. So Nagraj, POSI immune is for vasculitis, not linear pattern. Anna, you are just again go back and revise. You are getting confused. So indications for emergency dialysis, number one, if the patient has got any one of the serious uremic feature, any one of the serious uremic feature is present, becomes indication for emergency dialysis. Which are the serious uremic indications? Only 5 in number. There is encephalopathy, convulsions. Encephalopathy, convulsions. There is pericarditis, there is shock, and presence of coagulopathy. Presence of coagulopathy becomes the indication for emergency dialysis in acute kidney injury. Other than that, patient can be dialyzed when, number 2, patient is having refractory pulmonary edema. Refractory pulmonary edema. Patient is having refractory acidosis, pH less than 7.20. Patient is having refractory hyperkalemia. Patient is having refractory hyperkalemia is present, or patient is having severe azotemia, that is urea level more than 100. Urea level more than 100. or if the patient has ingested dialysable toxin. If the patient has ingested dialysable toxin, you want to go for emergency indication for hemodialysis. Among the ingested dialysable toxin, we want to know which are the common suicidal toxin in the world, which are the most common accidental toxin in the world, which can be removed by dialysis. Harrison has been kind to us in giving us a list of 4 drugs. Suicidal accidental toxin removed by dialysis. The suicidal toxin indicate salicylate poisoning and the use of polyethylene glycol, industrial solvent, polyethylene glycol. And accidental toxin indicates accidental contamination of ethanol with methanol, accidental lithium overdose in a psychiatric patient. Lithium overdose in the patient can cause indication for emergency dialysis. Emergency dialysis. So what we have got here? Clarity. So we want to know specific answer. So how we did the journey? We started with physiology. We understood the symptoms. We understood the screening test, urine analysis and its interpretation. We know how to classify acute, chronic, how to confirm diagnosis, how to manage each one of them. Now we complete with our the treatment modality, that is renal replacement or dialysis. So we have written down indications for emergency dialysis in acute kidney injury. Emergency dialysis or acute kidney injury we have written. So going forward, we have got here. So what we have here is hemodialysis versus peritoneal dialysis. Chalo, complete it for me. Hemo versus peritoneal dialysis. Hemodialysis requires intravascular access. Hemodialysis requires intravascular access is present. But intravascular access associated with risk of both sepsis and bleeding. Associated with risk of both sepsis and bleeding. Availability, it is having limited availability because every hospital has got a limited number of dialysis machine. The cost is also higher because patient has to purchase the special filter, travel to the hospital. Risk of infection is high because the same machine is used for multiple patients. The hemodynamic shift is also huge, leading to most common acute complication in the hemodialysis department is hypotension followed by hypoglycemia. The hemodynamic shift is huge. Hypoglycemia, hypotension can occur. But when you compare peritoneal dialysis requires a peritoneal catheter placement. Peritoneal catheter placement is required, which is associated with less than 1% risk of peritonitis. Availability, can be home based also. You have to only put peritoneal catheter. God has given everybody momentum. You can go home and do. Because you are doing it at home, cost is also lower. There is no risk of infection because you are only putting sterile fluid into your body. The hemodynamic shift is low. Hence, it is safe in patient with cardiomyopathy also. And the complication, if at all, is hyperglycemia with weight gain. Hyperglycemia with weight gain can occur in this patient. So now compare and tell me, among the two forms of dialysis that you have available, which one looks the better option? So what you will say? That when you look at hemodialysis, seems to be difficult to get appointment, cost is also high, complication is high. But peritoneal dialysis on other hand, looks very simple, it is cheaper also, and risk is also not there. So you tell me, which one is the better form? The better form. So जिनको लगता है, those of who you feel that answer is peritoneal dialysis is looking better, more green. So what I will tell you, in the last 3 minutes, I did not teach you medicine, but I did marketing for peritoneal dialysis. Imagine, peritoneal dialysis is like looking at recorded lectures on the app. Recorded lectures always tell you, see, all you have to do, download the app. You can do it at home. Pay less money also. Take less load on the heart also. No problem. Even if you have weak heart, weak motivation, you can eat and become fat also. But what they forgot to tell you, that it has got poor filtration rate. It has got poor filtration rate. Only 15 to 25 ml per minute. So remember this. Recorded lectures can never be as good as the live lecture. You must do it only when hemodialysis is not available, because hemodialysis is like our live lecture you are experiencing now. You all had to wake up in the morning. My God, 10 o'clock wake up in the morning. Sharam aani chahiye. Chalo. But still you have to pay more money. You have to put load on the heart. Or jo bacche break mang rahe, those of you are asking break. 1 hour you have become hypotension, hypoglycemic also. But hopefully end of the day, what you will go with? Excellent filtration rate. 800 to 1200 ml per minute. You go with a excellent filtration rate, and that is why it is always the most preferred form that you want to do. This will be always most preferred form of dialysis whenever patient needs, right? So take this forward. So we started with renal system, moving on to rheumatology, So those of you who want break, आप लोग 2 मिनट जाके हवा खा के आ जाइए, because just I am going to give you introduction. Then we will do rapid fire. Rheumatology is considered a super specialty in itself. So the questions in rheumatology are very simple relatively. The depth is very low. But what is the problem? Rheumatology is a fact-based topic. So either you know the answer or you don't know the answer. सोच के guess नहीं कर सकते. So pay attention. It's a rapid fire round only we want to play. So what we want to look at here? So we are looking at rheumatology. What is rheumatology? When you look at rheumatology, rheumatology is the study of systemic autoimmune disease. Rheumatology is the study of systemic autoimmune disease, is called as rheumatology. Is called as the rheumatology that we want to look at. So adaptive access is there, multi-organ involvement is there. That is rheumatology for you. In rheumatology, when you get any question on rheumatology, first step, don't rush towards diagnosis. First look at which group is there. How do you decide the group? Based on the characteristic feature or based on the screening antibody before you go for final diagnosis. So what we do? The most common group, needless to say, is the lupus group of disease. When will you say lupus disease? When patient comes with wolf bite rash and or patient is having ANA positive. Either there is lupus like rash or patient is having ANA positive. You know, diagnosis is lupus group of disease. Among the group, individual diseases are there. What they are based on? Among the group, you look for the characteristic feature and antibody present. Needless to say, Most common lupus disease is SLE. The differential diagnosis is scleroderma and the rare cause is Sjogren's syndrome. Rare cause is Sjogren's syndrome. We are going to discuss all of them. So come on, be charged up. I have given you enough warm up starting time. Now it will be totally rapid fire. Totally rapid fire. Right? Chalo, let's go to the next one. There is arthritis group of disease. In arthritis group of disease, there is the joint deformity. But how it is? Irreversible. Joint deformity should be irreversible. Focus on this, please. Joint can be affected in lupus also, vasculitis also. But irreversible nature is a hallmark of arthritis syndrome. Or patient is RA factor positive. Very important question. What is RA factor? It is IgM type of antibody against the Fc portion of IgG. Very common question. The IgM type of antibody against the Fc portion of IgG is RA factor. In patient with arthritis question, I want you to look at the pattern of joint involvement so that you can identify whether disease is rheumatoid arthritis, spondyloarthropathy or crystal induced arthritis. Coming to the third group, if the patient is having vasculitis syndrome, when they have purpuric skin rash or ANCA positive, in these patients, look at size of the vessel involved, whether it is large vessel, whether it is medium vessel or whether it is small vessel vasculitis. We want to know. So Haseen Multani, very good question. Irreversible means irreversible deformity. X-ray shows bone erosions. Very good question. Irreversible means bony deformity. Soft tissue reversible, but bony deformity irreversible. That's what is our three important topics in rheumatology. The extra one is the myositis, which we will complete our last page with. So in this DVT session, I want us to revise all these systems one by one group of disease. I want you to revise and complete our session with the topic of myositis. Simple approach. Okay, chalo, let's go for it. The best screening antibody in suspected autoimmune disease is our ANA, maximum sensitive, most common antibody in the autoimmune disease is anti-nuclear antibody. Important when you do immunofluorescence pattern is going to tell me probable antibody and the probable diagnosis. Probable antibody and it is going to give me the probable diagnosis in this patient. So each pattern when it is present, I want you to tell me, look at the pattern, what is the antibody, what is the probable diagnosis. The first one, let me look at this closely. When there is a homogeneous pattern, when there is the homogeneous pattern, uniform staining, homogeneous pattern of ANA on the immunofluorescence, it indicates the presence of anti-dsDNA or the presence of anti-histone antibody, which is present in the topic of SLE, either idiopathic or drug induced. Answer is SLE, we can say. So when patient is having ANA positive in homogeneous pattern, most probable diagnosis is SLE. But question change. If the patient is having centromere pattern, patient is having a centromere pattern like a spindle, centromere pattern is seen It indicates presence of anti-centromere antibody, which is specific for the diagnosis of CREST syndrome. Diagnosis of CREST syndrome, which is another name for limited form of systemic sclerosis. Another name for limited form of systemic sclerosis is the centromere pattern of immunofluorescence. Centromere pattern seen with CREST syndrome. Remember, we will enumerate all these features, but rapid, okay? Everybody, be ready now. When patient is having the pattern, which is our nucleolar pattern, double nucleus type, nucleolar pattern, corresponds to the presence of anti-SCL70, also known as anti-topoisomerase 1 antibody. Topoisomerase 1 antibody. This is diagnostic of our diffuse form of systemic sclerosis. Diffuse form of systemic sclerosis you can diagnose. SSC is systemic sclerosis. And finally, it is the speckled pattern, which is most common in practice. Can be seen with anti-Rho, anti-La, can be seen with anti-Jo, can be seen with patient with anti-U1 RNP. What are the diagnoses respectively? Speckled pattern can be seen with multiple disease. That is why common in practice. Anti-Rho, anti-La, specific for Sicca syndrome. Anti-Jo, specific for myositis syndrome. PM more than DM, polymyositis more than dermatomyositis. And U1 RNP, specific for MCTD, mixed connective tissue disorder. Specific for MCTD, mixed connective tissue disorder. So 4 patterns we have seen here. So homogeneous pattern, there is centromere pattern, nucleolar pattern, and speckled pattern of ANA, which tells me probable diagnosis, not confirmatory. These are probable diagnosis that we can derive. Once we come to the group, I want you to tell me salient feature of each and every disease. P, polymyositis, PM, polymyositis, and dermatomyositis. Polymyositis, dermatomyositis we want to see. We will see in the image, no? ये सब image तो दिया हुआ है आपके सामने. So start with the lupus disorder. Come on, everyone. Ready? Lupus disorder. Diagnosis is done when Euler score is more than 10. Very good. Based on the 12 clinical and 5 immunological tests. What are the 12 clinical factors? Presence of malar rash and the presence of discoid rash 1 and 2. Presence of oral ulcer, presence of alopecia, presence of serositis, presence of renal involvement, presence of CNS involvement, presence of hematology involvement. You want to see all 3 cell line, RBC, WBC and platelet. But the most common organ affected in 85% of the cases is the joint synovitis, which is always, as I told you, non-erosive in nature. That is called as the Jacob's arthropathy. So what we have gone through in the diagnosis of SLE, for we need Euler score more than 10. Number 1, malar rash, 2, discoid rash, 3, oral ulcer, 4, alopecia, 5, serositis, 6, renal involvement, 7, CNS involvement, 8, hemolytic anemia, 9, leukopenia, 10, thrombocytopenia, and 11, most common is the synovitis, which is non-erosive nature, is important. Which are immunological criteria? They include ANA, most specific star anti-Smith, anti-dsDNA, presence of antiphospholipid antibody, and persistently low serum complement levels. Persistently low serum complement levels can be used for diagnosis. Which is no longer recommended? DCT is out. DCT, direct Coombs test, is no longer the correct answer. That is the important update to know. DCT no longer part of diagnostic criteria for SLE. Which are the prognostic antibody? I will give you antibody. You tell me their role. Anti-Ro, anti-La is the only antibody to cross the placenta. Only antibody to cross the placenta, and that is why it is associated with increased risk of congenital SLE. But at the same time, it is good in mother because it is protective against glomerulonephritis. It is bad for the child but good for the mother, protective against glomerulonephritis. Very good. I was waiting for this. That who is this very good boy? Girish Iyer. Chalo. Very good. I was waiting for the 12th feature, that is fever. Very good. The 12th clinical feature is the fever. So I was waiting. Slick criteria, sab log, everybody is going okay, okay. Good, good, good. I am happy. You are all aware is the fever. Very good. Correct answer. Then we are looking at the presence of anti-ribosomal P. Ribosomal P and the neuronal antibody, which will predict the CNS involvement. We have got the role of anti-platelet and the anti-erythrocyte antibody, which predict the hematology involvement, can be seen. Predict increased risk of CNS involvement. Predict increased risk of hematology involvement. I am going to see. So in SLE, the most common lupus disease, very, very important, is the role of antibody. Must know chart. Role of antibody. The diagnosis comes from slick criteria, and we need to know the prognostic antibody, predict risk of congenital SLE, CNS involvement, hematology involvement, predicted by presence of antibody, right? So this is SLE. All confirmed patient of SLE must receive steroid. Steroid is the first line of treatment. First line of treatment is steroid. Okay, coming to next one. Only anti-Ro, Shivam Sethi, only Shivam Soni, only anti-Ro crosses the placenta. La is an associated protein factor. That's why we do it together. Only correct answer is anti-Ro antibody. Okay, chalo. Most common cause of death in SLE. Most common cause of death is heart failure. Is the most common cause of death in patient with SLE. Most common cause of death is going to be SLE. Yes, APLA. We can do cardiolipin. We can do the diluted Russell Viper venom test. Yes, correct answer. Direct immunofluorescence. Direct. Okay. Coming to second topic. Everybody, lupus, second topic is scleroderma, systemic sclerosis. Tell me characteristic feature. In systemic sclerosis, characteristic feature number 1, patient has to have autoimmunity, must be there, that is ANA positive. Patient should be having autoimmunity, that means ANA positive. Number 2, patient should be having areas of skin fibrosis. Patient should be having areas of skin fibrosis or organ that is visceral fibrosis present. Areas of skin fibrosis and areas of visceral fibrosis present, along with microangiopathy, which can be detected on the nail fold capillaroscopy, These are diagnostic tests for systemic sclerosis. To confirm diagnosis, ANA should be positive, areas of fibrosis along with microangiopathy confirms systemic sclerosis. We divide them into two types, limited and diffuse, along with palliative treatment. Come on, fill up the column for me. In the patient with limited systemic sclerosis, it is also known as CREST syndrome. Because C stands for calcinosis, R stands for Raynaud's phenomena, E stands for esophageal dysmotility. S stands for sclerodactyly. T stands for telangiectasia. In this patient, suspected patient of CREST syndrome, diagnostic antibody is to go for anti-centromere antibody positive. Anti-centromere antibody positive confirms the diagnosis in this patient. But in this patient, risk of organ involvement is less. So what about the diffuse form? In the diffuse form, there is increased risk of organ involvement. So accordingly, I will have to give palliative treatment also. The lung involvement most common occurs in form of NSIP, which is responsive to steroid. Renal involvement occurs in form of GM, responsive to ACE inhibitor therapy. The dreaded cause of death is pulmonary hypertension treated with iloprost. The mononeuritis multiplex asymmetrical neuropathy, responding to steroids, and cirrhosis can occur only organ in limited form, also responding to steroid. NSIP, non-specific interstitial pneumonia. Is NSIP. It is a type of interstitial lung disease. Mom nahi Dr. Anjali, MNM, mononeuritis multiplex, seen with the anti-topoisomerase 1 antibody. The topoisomerase 1 positive confirms diagnosis of diffuse form. Of systemic sclerosis for you. Pulmonary arterial hypertension, PAH, pulmonary arterial hypertension. Agastya Saxena, why iloprost, why not phosphodiesterase? That you read, beta, Iloprost is drug of choice in severe cases. You want to give that. Very good. Chalo, next one. Go for the Sicca syndrome. Okay, what is prognostic antibody? In systemic sclerosis, prognostic antibody is the antifibrillin or the U3-RNP, which is associated with risk of pulmonary hypertension and RPGN. So in patient with scleroderma, we have written what are characteristic feature, what are the findings, organ involvement, and the diagnostic prognostic antibody we have written. Prognostic antibody we have written. So coming to third topic, that is Sicca syndrome. Chalo, fill in the blanks for me. Most common organ affected are the exocrine glands. Most common organ affected are the exocrine glands. Most common extraglandular feature. Most common extraglandular feature is arthritis. The dreaded organ involvement is lymphoma. The specific and prognostic antibody are the same, antero-antila, which are also known as anti-SSA and SSB respectively, is known as anti-SSA Sicca syndrome A and Sicca syndrome B respectively, we can call them. So the 3 lupus disorder we completed. See how fast it is. That is all in rheumatology. Only 5 pages and you are done with rheumatology. This is all you have to keep revising. Classification and role of each antibody in diagnosis and prognosis of disease. So we completed lupus group of disease. Coming to next group, arthritis group of disease. Tell me, if patient comes with inflammatory polyarthritis, means how many joints are affected? More than 5 joint involvement is called as inflammatory polyarthritis. Is called as the inflammatory polyarthritis. We want to see the 2 differentials of inflammatory polyarthritis. Is difference between rheumatoid arthritis and the spondyloarthropathy, which is a group of disease. We are going to write it. The most common cause is the rheumatoid arthritis. The differential diagnosis is spondyloarthropathy. Is the spondyloarthropathy. How to differentiate between the 2? Come on, help me with me. In the rheumatoid arthritis, it is called as seropositive arthritis. RA factor is positive. Family history is negative. Majority are sporadic disease because HLA-D4, HLA-DR4, HLA-DRB1 is associated with RA, but it has got poor transference to next generation, poor penetrance to next generation. Prognostic antibody in Sicca is same as diagnostic antibody in Sicca. Both are the same. Antero-antila, ये both are the same. यहाँ पर mark किया मैंने. They are diagnostic also, prognostic also in Sicca. चलो. When patient has got axial involvement is rare and late. Primary site of joint involvement is synovitis. Synovitis. Okay. Predominant feature is articular. And first line of treatment is DMARDs. Must give DMARDs to all the patient with confirmed diagnosis of RA. Confirmed diagnosis of RA. So in RA, most important is joint deformity. Most important is joint deformity. And the most famous we have got is the swan neck deformity. Most famous is the swan neck deformity, which is irreversible in nature. It is a bony deformity that is hallmark of rheumatoid arthritis. It is hallmark of rheumatoid arthritis is present. You can compare now. So when will you say patient is having rheumatoid arthritis? When patient is a young female, female dominant polyarthritis, presents with polyarthritis more than 5 without family history, mainly with joint complaint, treated with DMARD. But when to mark? Answer as SPA. spondyloarthropathy are considered RA factor negative. Family history present in majority. Because genetic disposition is with HLA-B27 positive. Axial involvement is relatively common. Primary site of joint involvement is enthesitis. Predominant feature is extra-articular, which we are going to write down. First line of treatment is NSAIDs. All of them have excellent response to NSAIDs. That is why difference is there. Polyarthritis, RA is there, give DMARD. If SPA is there, you want to give NSAIDs. But in SPA, important is extra-articular feature is important. So what are the different SPAs? We are going to write down. SPA is a disease of group of 4 disease. Number 1, first disease, the first SPA is the ankylosing spondylitis. The first SPA is the ankylosing spondylitis. What are the points about it? Ankylosing spondylitis is the only disease which is more common in males. All others are equal in both gender. Only disease more common in males. So 20 to 30 years they will present. 90% are familial because they are having HLA-B27 positive. But what is the extra-articular feature? They are preceded by recurrent unilateral anterior uveitis. Uveitis precedes the sacroiliac joint involvement. So the main problem is uveitis. So we are going to be referred by the ophthalmologist. When a uveitis patient is referred for low back pain, diagnosis is ankylosing spondylitis. The number 2 spondyloarthropathy, group of 4, the number 2 spondyloarthropathy is the psoriatic arthropathy. The number 2 SPA is the psoriatic arthropathy is the number 2. So most common cause of death in RA is also heart failure. Most common cause of death in RA is also heart failure. But in psoriatic arthropathy, what is important? It is important the pattern of joint involvement mimics rheumatoid arthritis. But it can be differentiated by early DIP involvement. Looks like RA, but can be differentiated by early DIP, distal interphalangeal joint involvement you want to look at. And there will always be 85% will have skin or nail changes. And the most common extra-articular feature in the psoriasis is the oncolysis, that is nail peeling. That will help you diagnose the disease. So we want to look at the pattern of the disease and the preceding symptom. They are all RA factor positive. All can be HLA-B27 positive. The third SPA is the IBD associated inflammatory bowel disease associated arthritis. The third SPA, group of 4, third SPA is the IBD associated arthropathy, which is more common in Crohn's disease as compared to ulcerative colitis. It predominantly affects upper limb joints are involved. That is the shoulder and elbow are involved, and the majority are preceded by the diarrhea. Majority preceded by diarrhea. But the rare but specific skin manifestation, the rare but specific feature of inflammatory bowel disease, rare but specific feature of inflammatory bowel disease is the pyoderma gangrenosum. Rare but specific feature of inflammatory bowel disease is the pyoderma gangrenosum. And the fourth, last in the list, but most common cause of the spondyloarthropathy is the reactive arthritis. Reactive arthritis is most common cause of SPA, spondyloarthropathy. It is most commonly preceded by the chlamydia associated UTI. Most commonly preceded by chlamydia associated UTI, and the rare but specific feature is the presence of keratoderma blenoragicum. Which is present over the soles and the palms. You can see. So when patient is having spondyloarthropathy, first line treatment is NSAIDs, not DMARDs. So in this patient, identify the cause and treat them accordingly. But if what will happen if patient is a case of inflammatory pauciarthritis? Inflammatory pauciarthritis comes to you. Come on, give me the answers here. Inflammatory pauciarthritis. When the patient is having less than equal to 4 joint involvement, you must look at the point about crystal induced arthritis. Inflammatory pauciarthritis indicates presence of crystal induced arthritis. Among the crystal induced arthritis, the more common cause is gout. So tell me the pattern in gout. Gout is a disease of middle-aged males who presents with inflammatory monoarthritis. Gout is a disease of middle-aged males who presents with inflammatory monoarthritis with great toe or the ankle joint involvement. Great toe or the ankle joint involvement. But diagnosed when you get needle-shaped crystal, when you can get the needle-shaped crystal having the strong negative birefringence. Strong negative birefringence is diagnostic of the disease. Needle-shaped crystal confirms the diagnosis in this patient. Right? Here also, first line treatment is only NSAIDs. You don't have to give DMARDs in crystal also. You want to give NSAIDs. But the differential diagnosis for gout, is the topic of pseudo-gout. The differential diagnosis is the topic of pseudo-gout is possible. In the pseudo-gout, there is deposition of calcium pyrophosphate. There is the deposition of calcium pyrophosphate crystal, and hence it is called calcium pyrophosphate disease also. Called as the calcium pyrophosphate disease also. It is a disease of elderly males. Presenting with oligoarthritis. Among the oligoarthritis, most common joint affected is the knee joint, followed by the hip joint and the shoulder joint. And gold standard when you get rhomboid shaped crystal. When you get the rhomboid shaped crystals with a mild positive birefringence. Mild positive birefringence confirms diagnosis for you. So inflammatory polyarthritis is there. You have to choose answer between gout and pseudogout. Clinical scenario is very typical. Diagnostic test we have written, common pattern, common joint also we have written. Which brings us to the third group of disease, and that group is our vasculitis syndrome. Third group is vasculitis syndrome. I just want sign and diagnosis, that's all. In vasculitis syndrome, I only want sign and diagnosis. What we have got here? The presence of halo sign on the color Doppler study. Halo sign on the color Doppler study of the temporal artery is diagnostic for giant cell arteritis. It is diagnostic of giant cell arteritis, GCA. Halo sign on the color Doppler study. This is alternative to biopsy. This is the alternative to biopsy if patient does not do. Drug of choice is steroid. Dreaded complication is blindness. Dreaded complication is blindness. But if the patient comes with young case of stroke, young case of hypertension, or presents with myocardial infarction, I want you to suspect Takayasu's disease. In the Takayasu's disease Takayasu's can affect all the direct branches of aorta. Hence it is called as aortic arch syndrome. Takayasu's disease is suspected when patient is coming with the CVA, hypertension, MI. Hence it is called as aortic arch syndrome. Gold standard test is MR aortography. Gold standard test is MR aortography, which shows multi-vessel involvement. Diagnosis is confirmed. When MR aortography shows multi-vessel involvement, diagnosis is confirmed on the aortography. Gold standard, Monica, is yes, gold standard is to go for biopsy. This is alternative test. Gold standard is biopsy, but this is alternative test. Many elderly patients refuse consent to biopsy. This is the alternative test, is to do color Doppler. But the only disease which comes with the renal microaneurysm. When you do microaneurysm right at the bifurcation, when you get presence of microaneurysm at the bifurcation of the artery, what is that bifurcation also called? Nodes. That is bifurcation of the arteries. When you look at the metro junction is also called as nodes. On the renal angiography, there is only one diagnosis. This is diagnostic of PAN, polyarteritis nodosa. Diagnostic of PAN, polyarteritis nodosa. It is called multiple arteries are inflamed at the nodes, causing microaneurysm formation. That's why we called it PAN. But the mucocutaneous syndrome is the Behçet's disease. In vasculitis, we have got mucocutaneous presentation. when there is the mucocutaneous symptom, we will suspect Behçet's disease. But Behçet's is famous for the variable vessel involvement. Even though we classify Behçet's disease as a small vessel disease, it can come with large and medium vessel involvement also. The essential criteria for diagnosis of Behçet's disease is the presence of recurrent, painful oral aphthous ulcers. Is essential for the diagnosis of Behçet's disease. But in patient with Behçet's disease, the dreaded complication is blindness. Which occurs due to untreated hypopyon. And when the patient is having erythema nodosum on the skin, that is why we call it the mucocutaneous syndrome. Mucosal involvement, oral genital ulcer with skin involvement, think of Behçet's disease. But the danger is because of hypopyon, leading to blindness. This is our vasculitis syndrome. So as I told you, the last page I want you to complete inflammatory myopathy. So help me with this simple 3 boxes to fill. Patient comes with rash, is absent with proximal muscle weakness. Rash is absent with proximal muscle weakness is the polymyositis. Distal more than proximal is only one, inclusion body myositis. And rash is present, it is dermatomyositis. So inflammatory myositis also has got 3 diseases. Among the rash is absent, proximal weakness most common, polymyositis. Distal more than proximal, only one, inclusion body myositis. Presence of rash is dermatomyositis. Dermatomyositis has got hyperpigmented rash over the following areas. Hyperpigmented rash is present over the following areas. So tell me, which are these signs that we say? We can get the heliotropic rash over the eyelids. Heliotropic rash over the eyelids can be present. But the most specific is the Gottron's rash. Which is present over the knuckles, MCP joint. There can be presence of the back. Over the back is called as the shawl sign. And over the neck is called as the V sign of dermatomyositis. So proximal muscle weakness is there, along with having any other involvement. Think of myositis, ANA positive, rash is absent, classical is poly, any one rash is present, dermatomyositis, but distal more than proximal is one, inclusion body myositis, right? So one by one we completed our entire 2 topics of rheumatology and renal medicine. Always remember this line. In MCQ exam, you always prepare as if you know nothing. But when you go to the exam, go as if you know everything. Because in MCQ, answer is in front of you. And it's the confidence that can cross the barrier, which preparation cannot cross alone. So I can see from the chat All of you are preparing, putting in your best effort. Don't give up. Keep reading, keep preparing, but on day of exam, go on a high. Go as if you know everything. All the very best. So we will take break, means you can all move about and come. We will do a little dance till we go to the next session with Dr. Achi.